an invaluable supporter of the work of Thalassemia International Federation, as so many scientists and medical specialists across Egypt, but also across the Eastern Mediterranean region and Middle East. Hence, the important improvement that the region has had in addressing hemoglobin disorders through the years. I would like, on behalf of the Board of Directors and its President, Mr. Androulla, to thank the organizers for this invitation to present the unmet patient needs prior and during rather than post, because we are really not past this tragic pandemic, and to underscore the fact that these data are still under review and they're still being assessed, but are going to be presented in this presentation, which has been prepared with the support and collaboration of the head of the T patient advocacy group, Mr. George Costantino. So the mission of TIF has remained unaltered since its establishment in 1986, and so it is vision to support the effort of the governments, the stakeholders, the patient organizations, so as to provide an equal and timely access to quality health, social and other care that is needed for patients across the world. Despite the considerable work done initially by World Health Organization, but also by many other stakeholders, including the European Union, that has focused in the last decades considerable attention on rare diseases into which hemoglobin disorders are included. And despite the disease-specific resolutions that have been issued by World Health Organizations since the early 1980s, the fact is today that the hemoglobin disorders are still underestimated, and we do not have an accurate assessment of their contribution at the national, regional, and international level, and mostly with reference to thalassemia. Although considerable work has been done on the contribution of sickle cell disease because of the high numbers, we still need considerable work to be done with reference to thalassemia. There is still lack of global and national efforts on updating the existing and appropriately designed new epidemiological work in still many countries with large populations, and there's still absence of comprehensive disease-specific national registers and control programs in the greatest majority of these countries, where more than 80% of our global community is born and lives. We are all aware, of course, today, consequent to the work of World Health Organization, but to the work also of national governments and stakeholders, as well as patient organizations at the national level and Thalassemia International Federation at the international level, that hemoglobin disorders and thalassemia in particular, as a focus of this presentation, is not only a disease prevalent in the thalassemia zone that was previously considered as confined, as being geographically confined, as a disease geographically confined in the malaria endemic or previously endemic countries of the world. We are fully aware now, and for some time now, that heavy population movements across the world have literally introduced hemoglobin disorders into the indigenous population of almost every country around the world. And in more recent years, migration has been very strong in central, western, and northern parts of Europe, into which these disorders were not known or have not been addressed in previous years. Despite also the fact that hemoglobin disorders have been recognized as a huge public health problem in 71% of the countries that contribute to 89% of all the births globally, as well as the third of the 5 common disorders, congenital disorders that account for 25% of all birth defects. They are still considered amongst the non-communicable, neglected diseases across the world. And despite the huge efforts that have been performed in more recent years on assessment of their contribution in the global disease burden, this has not been achieved for thalassemia, although it has been achieved to a certain level for sickle cell disease. So they still are considered largely neglected diseases, and we can see these based on the survival rates, the comorbidity levels, the morbidity and mortality rates of these diseases across the world. The numbers, as a consequence of the absence of micromapping, as I previously mentioned, and the lack of better designed epidemiological work, the numbers that have been published in literature by scientists at the national level or by work that has been officially performed in collaboration with Thalassemia International Federation, as well as ad hoc delegation visits made by Thalassemia International Federation, we can clearly see that the carrier rates, as we see on this colorful map, across Western Pacific, across Southeast Asia, represented by the subcontinent of India, as well as the Middle East region shown here, the carrier rates across these countries, as well as the prevalence of patients across many countries of the world, as published, certainly underscore the fact that the numbers that are published with reference to the annual births with major hemoglobin disorders and to the prevalence of these diseases, these numbers seem to be almost certainly grossly underestimated, and there is a lot of work needed because this kind of work will certainly contribute to a better assessment of their contribution to the global disease burden and hence to better planning. So unmet patient needs across the world are many and are hugely heterogeneous, both across the world but across countries within the same region as well as within individual countries, because certainly different healthcare system infrastructures, public health, medical and social infrastructures, different health priorities in different countries in different regions of the world, as well as different economies. And I'm just showing here the Human Development Index across the globe, which is related also to the income level of various countries. And all I want to show you this busy slide is that most of the countries in which we meet thalassemia and other hemoglobin disorders are countries within the low income, low middle income countries of the world. Hence, we are facing considerable challenges in bringing about policies to appropriately control the disease in terms of prevention and clinical management. So the unmet challenges across the world include, with very few exceptions, the very confined number of national control strategies that are well coordinated in terms of prevention and management, and the absence of disease-specific registries. So these diseases are hugely neglected in terms of their epidemiology, and there is still considerable work to be done. And consequently, because of the absence of such data, there is absence or very limited work to be promoted with regards to appropriate planning of health and public social services and programs in a country. And of course, consequent to this, there is failure to accurately describe the contribution of hemoglobin disorders to the global disease burden and to actually map the patient needs across the world. So the absence of sufficient and quality evidence on the numbers and the distribution across a country, across a region, coupled with poor and weak health care and public infrastructures. Another health-related priorities, acknowledging the fact that still many countries are addressing communicable diseases, and the example is the current COVID-19, the SARS-CoV-2, which is the virus causing the COVID-19 pandemic, and the absence of healthcare systems in the majority of the countries where patients with hemoglobin disorders are born and live on universal health coverage are still contributing to the many unmet needs of patients across the world. Now, Thalassemia International Federation through the years has been mapping the needs of patients in many regions and in many countries within these regions across the world. In 2018, there was a survey conducted, which was prior to COVID-19, of course, amongst for a year between January and December of 2018, with responses obtained from 62 national thalassemia associations in 48 countries, representing the responses of nearly 4,000 patients globally. A second survey was undertaken between March 15th and May 15th, 2020, in order to map the challenges and the difficulties that the patients were facing during the COVID-19 pandemic in 48 national thalassemia associations that were included in the 62 national thalassemia associations included in the 2018 survey, covering 42 of the 48 countries included in the 2018 survey. Nearly 3,500 patients responded. The methodology was through a survey and in addition with regular contact with community groups through social media, communication platforms, and virtual meetings. Well, the situation is rather sad, and although analysis is still in progress, there's considerable analysis that we need to address in a more structured way. But for the purpose of this presentation, it's important to show the challenges that our patients are facing on a global level. The criteria that were placed in terms of assessing their responses were taken from TIF guidelines for the management of transfusion-dependent and not transfusion-dependent thalassemia, and they were assessed according to the recommendations reported mentioned in these guidelines. So nearly 65% of the patients responded that do not have access or have interrupted access to adequate blood with reference to what the pre-transfusion hemoglobin of these patients were. And 55% reported have serious interruptions. Nearly 97% of these came from the developing countries. The responses, just for the sake of clarity and simplicity in this presentation, were separated responses from patients in developing countries with a DC and responses obtained from the developed economies designated as DE. So nearly 90% had one or more comorbidities including diabetes, cardiac complications, liver disease, hypogonadism, and bone disease. 70% came from the developing countries across ages 18 to 35, whereas the 30% that came from the developed economies, 95.5% of these were over 35 years of age. Nearly 70% were reported as being infected with viral hepatitis B and or C. Nearly 83% of these responses came from the developing countries across ages between 18 to 35, underscoring the fact that there is still, to a certain extent, smaller and larger in some parts of the world of transfusion-related still infection with viral hepatitis, whereas nearly 18% in the developed economies reported as being infected, but 97% of these were patients over 45 years being infected in the previous years prior to the implementation of possibly NAT testing. Now, nearly 63% of the responses reported, the patients reported receiving inappropriate or suboptimally processed blood, as this is described in the recommendations of the international experts in our TIF guidelines. And 100% of these responses came from the developing countries. And the indicator is 2 or more parameters lacking. And by processing, of course, as recommended by international experts in the guidelines, it is a very important percentage that reports receiving inappropriate. Now, one of the most important challenges, sadly, is that less than 10% of the global population has access to appropriate and uninterrupted chelation as per their needs. And nearly 92% of these means that do not have access to chelation, and nearly 100% come from the developing countries of the world. Now, another worrying element of this information is that nearly 80% of a global patient population contributes with out-of-pocket funding for their treatment and drug-related expenses to a small or large extent. And nearly 90% of this is in the developing countries, where we are fully aware that the healthcare systems are under transition towards becoming universally covered based healthcare systems. The nearly 11% of the responses that come from patients of the developed economies are usually related to private consultation, but mostly with expenses on MRI testing. Another important information here is that nearly 83% of the responses, or of the patients rather, reported blood-related adverse unwanted reactions or events, 76% of whom came from the developing countries, and the 25% of the patients that reported in the developed economies actually were related to patients over 45 years, and mostly with non-transfusion dependent thalassemias that initiated transfusion at a later point in time, so usually related with our immunization reporting. Another important data here is that less than 5% of our patients are provided with expert and organized multidisciplinary care. This is really challenging, as nearly 5% only are provided with multidisciplinary care, and this is mostly in the developed economies. So 96% of the responses of the patients that reported as having multidisciplinary care well organized comes from patients of the developed economies. So the rest of the people have no organized multidisciplinary care, and less than 3% have actually reported as having access to reference centers, and 90% of these again come from the developing part of the world. The other important element here that is of interest to all of us is that nearly 70% of the patients have reported as not receiving healthcare services from hematologists or pediatricians with specific expertise in hemoglobin disorders. 58% come from the developing, but also 42% came this time from the developed economies. And our guess here, and again, I have to repeat that these data is in the process of further analysis, but in the developed economies is probably due to the fact that migrants now are spreading in parts of Europe and parts of the Western world, where hemoglobin disorders were not known or medical specialists had very little experience with. Now, nearly 73% report as feeling social isolation or marginalization, and this is divided between the developing and the developed. Well, 62% have reported, and these patients come from the developing world, but 38%, nearly 40%, also reported from the developed part of the world in terms of economy, always speaking. Nearly 90% of a question posed to the healthcare professionals report as not using or partially using the disease-specific guidelines for the management of patients. And there are no specific strategies addressing refugees and migrants in the countries that receive great numbers of such groups. So looking at this information in a sort of tabulated form, we are looking here at the situation prior, and the red bars are just signifying the responses that we have just analyzed during the COVID-19 pandemic. All I need to underscore here is that the most important challenge that has been reported on a global basis is adequacy of blood. So blood shortage has been reported across the world, reaching 85%. So the most important challenge is blood supplies, but also in the developing world, processing of blood as well has been another major challenge, with reports coming from a significant number of patients receiving whole blood instead of red blood cell concentrate, certainly a significant number not appropriately or according to guidelines filtered and antibody screened blood. Access to chelation has been slightly increased in the developing. Difficulties in access to chelation has also been reported, mostly in the developing part of the world, probably due to distances, climatic and environmental conditions that did not allow traveling, as well as the COVID-19 pandemic restriction measures. But most importantly, it has been observed in the developing part of the world rather than in the developed world. But of course, then multidisciplinary care, access to reference centers remains a huge challenge in the greatest majority of patients living in the developing part of the world. As far as social isolation and the feeling of social isolation is the other element that has been noticed to be happening during the COVID-19 pandemic, and this has been equally distributed amongst patients globally, both in the developing and in the developed part of the world. I tried for the part of this presentation to see the impact in the Middle East region in which this conference is being taken place. The results show that most of the challenges that have been faced during the COVID-19 across the world have been happening in the Southeast Asian region. Some of these challenges have been faced by patients reporting in the Middle East region, but as we see with the blue bar is the Middle East region responses. The brown part is the Southeast Asian region. The European is with lighter brown, and the West Pacific is with even lighter brown towards light purple. And having said that, the West Pacific region information is still being greatly analyzed. But what is clear here is that the challenges of blood adequacy, blood processing, access to population is faced mostly and greatly by patients in the developing part of the world. Patients in the Middle East have faced these challenges, but to a considerably lower extent. As I said, the West Pacific is being analyzed, but the European patients, which their data are clearly and more specifically analyzed, have not been facing such challenges almost at all, or for a very short interim period at the beginning of the COVID-19. Now, social isolation is the element that is shared across patients across all regions of the world, as we see with the 4 bars, to a lesser extent in Europe, but certainly across patients across all countries. So as far as the patient needs are concerned, according to the global reality, we still need to fight for the prioritization of hemoglobin disorders, for strengthening our epidemiological work, most importantly micromapping, strengthening healthcare systems to provide universal coverage in a truly patient-orientated and quality-directing healthcare system, which is the most important element in providing chronic patients with quality care. We need to have healthcare systems that provide universal coverage. And certainly we can do that because countries that have had disease-specific strategies in a patient-centered, universally covered healthcare system, such as these seen on this slide, Cyprus, Greece, UK, have certainly proved that the knowledge is there about how to effectively prevent and how to appropriately treat patients with hemoglobin disorders, and in this case, thalassemia. We have seen survival rates, we have seen patients aging, age distribution of thalassemia patients in Cyprus, looking at shifting to the right, where patients are aging and younger patients are in smaller and smaller numbers due to effective prevention, decrease in the number of annual deaths in these countries. So these can be achieved in universally covered healthcare systems in countries where hemoglobin disorders are given priority, and where we have disease-specific control programs. So the current status of prevention and clinical management of thalassemia across the world is not so good. We still have considerable work to have effective national control programs and quality management in countries where the prevalence of this disease is high. We can achieve social integration of patients, and here's the example of Cyprus regarding the fertility, the patient education, the number of pregnancies that we have achieved in Cyprus, 291, for example, pregnancies, giving 328 children from mothers with thalassemia major. And we need to fight for this because the advances are here with us. They should not stay on the shelf. We've been waiting for such dramatic achievements in science regarding better care and cure, and we have the two authorized innovative therapies with us in our hands, on our shelves. They should not remain on our shelves. So we need to provide better care so that our patients can receive these new innovative therapies that are with us now, both in terms of thalassemia, but also the huge advances in terms of sickle cell disease, and many that are still on the way to be authorized. Thank you for giving us this opportunity. Wishing you a very fruitful and productive conference as always, and congratulating you again under these challenging times that you still think and organize conferences such as this. Thank you.